All right, good afternoon, everybody. My name is Kristen Hammergren, and I would like to thank all of you for joining us for the Collada Spine webinar series. Today's webinar features speaker Dr. Maurice Collada, and he's going to be going over the key components of the Salem Spine Center. Dr. Collada is the medical director for the Salem Spine Center in Oregon, and he's been a practicing neurosurgeon with over 31 years of experience. He's an avid winemaker and the proud owner of Cubanissimo Vineyards. Today he's going to discuss the many challenges that face all healthcare providers in spine care and the strategies that Salem Spine Center utilize to face these challenges and those moving forward. He will include a discussion on clinical algorithms that his team created to direct patient care in a streamlined, cost-efficient, best practice manner to standardize patient care and improve patient outcomes. Dr. Collada will be answering those questions that you guys submitted on your registrations and any additional questions you guys might have during his presentation. So if you think of any questions, go ahead and use your GoToWebinar panel located on the right-hand side and type in the question box, and he will make sure to get to those at the end of his presentation. So with all of that, I'm going to go ahead and hand things over to Dr. Collada.
Well, welcome to all of you, and be assured it's a pleasure to share our story of the Salem Spine Center. Ours has been a journey that has had its pits and falls, but we've been able to rise above it. I wish we could do this sharing a glass of Pinot Noir, but we can still proceed, I am sure. The Salem Spine Center is a great source of pride, not only to all the spine surgeons that were crucial to put it together, including yours truly, but also to the hospital that had the wisdom to initiate it and make it happen. I think that by your interest, I know you're interested in all the transformational forces in medical care, and certainly our Salem Spine Center was an effort to be ahead of the curve when it comes to that. To give you a little bit of background, our hospital is the largest hospital in our region. There's some very smaller hospitals, but ours is the single largest one. It's where we do all our neurosurgical care and all our spine care. It's a 454-bed magnet facility that covers a catchment area of about 450,000 in population. And the spine specialists, but also the majority of practicing physicians in this area are independent practitioners. And I emphasize that only because it becomes a little very significant as we went forth to try to promote the Spine Center and to get buy-in, that we had to indeed put a package together that would convey to the spine specialist and the referring physician that this was a better service to the patients. They were at first very suspicious that this was just another way for the large hospital to direct care towards its own facility. The other thing that I think allowed this to happen, that is the Salem Spine Center, is not only the commitment that the hospital put forth to getting our program going, but I, without fanning my back too much, have had a long history of medical leadership in our area holding different positions. And so I know the practitioners in our area well, know the history well, and that gave me credibility as I went forth trying to promote the Salem Spine Center. One of the things that compelled us to move ahead and start thinking of the putting together of the Salem Spine Center is all the information that was coming out in the early 2000s, indicating the tremendous increase in healthcare costs, how unsustainable that was, how that would be putting pressure on, increasing pressure on the national deficit. And subsequently, we became acutely aware as we heard all the dialogue that the reimbursement formulas were going to be changing. We decided early on that we wanted to be ahead of the curve rather than being at the tail end. We felt that it never really works well when you have all the regulatory forces in play and you have nothing to argue against it. We knew that because of all the pressures that the cost pressures, and in particular, I might add, the cost pressures coming from spine care, that spine was going to be focused on rather aggressively as there was an effort to modulate healthcare costs. We knew about the fact that there was a substantial talk, and we know now that this is even more so, to change from a volume-based reimbursement formula to a value-based reimbursement formula. And although we all know that still has not materialized, we know that that's going to be the future. And again, we wanted to be ahead of this process. The way we looked at it, value-based patient-centered systems were going to be coming on, and we had two options. Either we took the bull by the horns and established our own physician direction and oversight, or we waited to all the mandates and all the other controlling forces, including forces from the insurance carriers. One of the things that we decided from the onset is to validate our system as we went forth. We also wanted to be aggressive in collecting outcome studies. We thought this was an essential component. Even though we had these discussions, with the background that I've given to you as part of the independent streak going on through our community, we could not just come in with this program and say, this is a better program, this is a change that you all can embrace. I think that in our community, but certainly throughout the United States, there have been a lot of change efforts that have gone for naught, have not produced any significant benefit for the practitioners, and certainly have not produced any significant benefits for the patients. We knew, however, that the pressure was going to be coming in, not only because of what I've talked about as far as the healthcare costs, but I think that anyone who's been in medicine for a long time, as unfortunately I have been, have seen too many errors, too many inappropriate studies, too many inappropriate treatments that occur even today, despite our intentions to do our best. In great part is because there has been no standardization efforts. There has not been any great dialogue on how to improve this. This is what we set out to try to change for spine care. I think that it's also the reality that in medicine, but very much in spine care, too much of our treatment practices are based on weak science. Very few of the studies are powered beyond at a level 1 class studies. And there's immense challenges, even in people who've been trying to do outcome studies, or doing reliable outcome studies. And we knew that this was the type of stuff that we were facing, but we wanted to, again, move ahead. We really realized as we went ahead that one of the key things that needed to happen is not only get physician buy-in, but also to convince them that developing an improvement mentality, a culture dedicated to improvement, was key to doing the best for our patients. And this became a core part of what we discussed as we started moving ahead with the Spine Center. Now, to go ahead and select how we would become a Salem Spine Center was a challenge. As I've already alluded to, we're all independent. Most of the spine surgical practices are totally disconnected. And as we looked at the existing spine center models, They were employed models and really did not fit our area. And also, we did not think we could get buy-in from even the referring practitioners if it was too much centralized. So as we looked at the different models, we were fortunate to have a very dedicated officer in our organization, who I believe may be in the webinar audience, who actually identified the Collada triage program as one that could serve us in that we could give better patient care, more timely patient care using their online triage program, but at the same time we would use that platform to proceed and develop the whole spine center on its back. As we went along doing this, one of the first things we had to do, besides working together to develop an appropriate history program that our callers could use to deal with patients, is we identified and cataloged our local spine care resources, started developing a relationship with them, and started defining among ourselves what would be an appropriate commitment to the referring docs and to our patients. And clearly, this was a major shift in how we were doing things, and we had really a small window so that we could get satisfactory buy-in. Again, I cannot emphasize enough how when you start any such program, it's key to make sure that the physicians believe that what you're offering is something better. So we started this really predominantly with the spine surgical services, with the spine surgical offices, and within a matter of 6 months, we saw dramatic shifts. In our own practices, the office efficiency was dramatically helped out by the spine center. We started seeing shifting from 75% non-surgical consultations to and less than 25 surgical consultations to absolutely the opposite, where we were seeing 75% that were purely surgical consultations and 25% non-surgical. The benefits of this could not be overstated, because this encouraged the spine surgical specialists to now give more of themselves. They were seeing the results in their offices, as I mentioned, but they were seeing the satisfaction that was being registered throughout the whole community. Primary care physicians were seeing, were having their patients being seen on a more timely and appropriate basis, and primary care physicians were given immediate feedback as to our reviews that we did online. And the surgeons, of course, were extremely happy because of what that slide suggests, that we had a lot of help in with the hospital setting the spine center together, and it gave us a lot, it helped our office efficiency markedly, and it helped the quality of our practices markedly. And similarly, we saw tremendous positive feedback from the primary care physicians, we also saw the same from the patients, who were now clearly being seen on a more timely basis if they needed surgery, and if they did not in any way by our review merit any sort of surgical consideration, they were spared those costs, and their care was on a more timely delivered. Now, as we went forth with the Salem Spine Center concept, we initially had the structure that I have just described, but we felt that we needed to have an articulation of the philosophy of our spine surgeons better documented. And as such, one of the things we started doing early on is working on algorithms, which I know has been presented to you as one of the key components, and indeed, it has been one of the key components in working out that that the algorithms between the spine specialists, there was a lot of give and take, as you well know. There's not of rigid guidelines when it comes to a lot of spine care. What we have is we did a lot of research, brought in our own practice experiences, and then basically took on with what we felt the core principles being patient-centered, science-based were available, but at the very least adopting best practice standards that we could commit to. All along the line, still keeping in mind cost effectiveness and tracking our outcomes. So we went ahead and started putting our algorithms together. The algorithm you have in front of you at this is the acute cervical and lumbar back pain algorithm. And what it conveys is the fact that we tend to have a conservative approach. We clearly identify red flags that primary care providers can utilize to expedite referral to the spine center, but we encourage them to, with these algorithms, to do a lot of the work themselves. We emphasize education. We emphasize conservative measures at the onset. We emphasize how making changes in lifestyle could be more significant than 5 spine surgeons. We generally empowered, by using the algorithms that we worked out, we empowered the primary care physicians on how to care for what we think is true, which is the majority of low back pain. And we shared with them the rationale why we had a conservative approach, how we felt that indeed surgical procedures, except in red flag circumstances, should be the last option offered the patient. So we use the algorithms to then, as I said, gel our philosophy as a group of spine surgical specialists, but also used it to go out and now start partnering with the primary care providers in our community and arming them with the information that would help them be better partners. Here what you have is the algorithm that we use in circumstances where we're dealing mostly with facet pain, and you see that we make a distinction between cases where there may be instability that might need to be addressed surgically versus those that do not. And clearly we tend to push for a conservative approach. In the lumbar herniated disc algorithm, you can still see the same philosophy. We really feel that the majority of cases, and I cannot stress this enough, I certainly stress it when I give the presentation to the primary care specialist, that the majority of back patients can be managed without involving the Salem Spine Center, and certainly without involving surgical intervention. Now, as we were buoyed, this is an example, by the way, of the pamphlet or the booklet that we give our primary care providers. We go out to their individual clinics. We give presentations as to the logic and the rationale behind our algorithm, and they feel generally, indeed, as partners of our center. I talked earlier about the importance of doing outcome tracking, and from the beginning, and you see again what are nationally recognized standards for outcome tracking of spine care. We include the oswestry, the NDI, work status. We also make sure we address mental health issues, and of course, patient satisfaction that would include how our spine center delivers its services. We used our outcome studies to help trigger peer review efforts. So after a certain threshold in which there may have been a setback in the NDI or the oswestry, we review all these cases, and we not only identify the nature of the problem that might have led to the poor outcome, but we compare that with our algorithms and see where we can learn. Clearly, there are circumstances that doesn't serve us, and then what we do is see if we can identify trends that would merit an improvement effort on the part of our organization. Now, as we initiated the Salem Spine Center to get a better alignment between the spine surgical specialist, the hospital, and the primary care, we then became emboldened and decided to go a step beyond. And what we recognize is the fact that we had a lot of great practitioners in our area, and I've identified some of the resources in an earlier slide, but they really did not have a smooth communication system. Care essentially was fragmented. And we felt that if we were going to take a step forward, not only did we need to use the algorithms and our education program to help the primary care providers, but we needed to have a system to also coordinate care with all those other individuals that give spine care, such as physiatrists, pain specialists. We certainly wanted to include consider psychological considerations in any aspect of our program. We brought in the perspective of imaging centers because too many times we were seeing in the plethora of imaging centers that were around us, studies being done incorrectly or poorly so that they were not useful to the spine surgical specialists, and we actually had to repeat these studies. So we decided to go ahead and develop an advisory council, an outpatient advisory council comprised of all these individuals so that we could figure out how we could communicate better. We also used this group to develop and vet, to develop further algorithms. We used this group to develop any policies that, as we got suggestions, merited consideration. And certainly, we used the input from the primary care providers to modify where needed what we were establishing as practice standards in our community. We use them, of course, also to help sell the program. I think I cannot emphasize enough that by the fact that they brought their input, they also helped give us perspective to help promote the program, and not just as just another product and another way of getting patients sent to us, but truly as a better way of providing spine care. This physician membership agreement is a summary of the agreement that we sent out to all the key practitioners in this Salem Spine Center. And what you see there is generating a spirit of collaboration and a spirit of commitment to staying up to date with our policies and staying up to date with our algorithms. And this has served us very well also. As we went ahead and advanced and had success in the outpatient area, we then became enthused to go further and take all the experiences that we and all the lessons that we had acquired by developing our outpatient spine center to within the hospital walls. The spine surgical specialists by this time were very much embracing an improvement culture, an improvement mentality, and using the input from all those folks within the hospital that in one way or another touch a spine patient when they come in. We started developing our own spine center of excellence. The initial efforts were directed towards taking input from all the folks that I have just mentioned and developing standardized orders, standardized clinical pathways, standardized goals and metrics that we would want to measure specifically inside the hospital. And at the same time, we staying committed to our initial concept of best science, best standard practice, but also cost effectiveness and patient-centeredness. We made sure that all these that we had appropriate metrics to continue to improve in all these areas. What you have in front of you is a scorecard that we review monthly, and in it, it includes some of the metrics that we continue to have that involves volume, because as you all well know, we're still living in a volume-based reimbursement paradigm. But we made sure we started using metrics that gave us a sense of where we stood in comparison to our peers when it comes to different aspects of press gaining and other aspects of routine tracking when it comes to spine care, such as reoperation, DVTs, mortality, infection, and so on and so forth. Initially, we had a lot of improvement room. We certainly had issues that were substantial, and coming to agreement took some effort. But like I said, once the spine surgical specialists embraced this, they embraced the idea of an improvement culture, this became relatively easy. Also, I cannot emphasize enough how rich the experience was of developing programs using feedback from our nurse partners, from the physical therapists. This was really a very satisfying experience as we move forth and as we continue to move forth with our spine center. The ultimate reward was the fact that we were in April 2013 recognized by the Joint Commission as a Center of Excellence, and I can assure you that they were equally impressed with our outpatient efforts and successes as they were impressed with our inpatient achievements. This is a collection of the beautiful faces that comprised the team at that time. The one that's left of me in the picture is Jane Ray, who is our manager of the Salem Spine Center. And as you go forth, if you consider embracing our concept, I cannot ever overstate how important it is to have someone that is organized, competent, has the necessary people skills to take the program forth. Even though the doctors, of course, are a key component, you need someone of that caliber to really take the program to be all that it can be. And she has been key, but all the other folks you see there, including our spine center nurse navigator, has been essential for our success. Now, to go on into describing some of the metrics that we measured in the hospital and some of the improvements we achieved, you see here length of stay for lumbar fusions, where we were able to achieve within a few years substantial reductions and, of course, substantial savings when it comes to costs. This was particularly so on the inpatient side for all type of spine cases, and you can see that in the graph as well. One of the issues that we contended with early on in 2011 is a frustrating incidence of surgical site infections. And our system, our program, and the mindset of the spine specialist was key to achieving the success that we have to date. There's different things that we instituted besides standardizing different approaches to how the patients were brought into surgery. We did also different changes inside the surgical suite. All of this led to what we very proudly have described the immense success for 2014 in not having any infections. In the discharge disposition, you see also that we have achieved great successes. One of the things that we had early on, 2011, 2012, we were seeing 83% patients going somewhere else than their home. And we know from national statistics and other programs that patients clearly do better once they go home, especially if they're armed with the right information. And one of the things that has been a key part of our program, and I have not mentioned adequately enough, is the education piece that we do for all patients going into surgery. We have an education piece that's now part of our spine center that goes to the primary care physicians when we go out and give presentations in their clinics. We have an education piece that we use for the community at large so that we can give them the information that allows them to take care of their back before they ever become a spine patient. But then once those patients need to go into to surgery, we feel that they do dramatically better when they're best prepared. And when they are really well prepared, they are more comfortable and the family is more comfortable taking them home. And that's what has led to the shift from 83% to 93% going on home. And we're seeing even further improvement in those areas. Here's an example of our collecting data as far as the oswestry and the NDI. And the numbers that we have are not numbers that we sit back on our laurels and just accept. We're always trying to improve them, but at least we have some comfort in that they compare very favorably with large existing spine centers throughout the country. So what you see is an effort that began early on to simply align the spine specialist better with the hospital. But because of the vision that was brought to bear early on and the success of the partnership between the Salem Spine Specialist and the Salem Hospital, we were able to evolve from a triage program, the Collada triage program, to a community spine center model that has helped our primary care, the physician, the patients, and certainly our practice immensely. And also the community, because as I said, we do lectures in the community at large. But it has led to the great achievements within our hospital of now being recognized as a center of excellence. And our improvement mentality continues and is evolving. So having said all that, at this stage, I guess I would welcome questions. I know we may be ahead. I may have sort of sped along, but let me just take a pause and welcome any questions you might have.
All right, guys, if you're not familiar with GoToWebinar, on your screen there is a spot to fill out questions. Just go ahead and type them in the space provided and send them to us, and I will read them off to Dr. Collada as you send them in. During your presentation, we did have a few come in, Dr. Collada, so we'll go ahead and start with those. One of the questions was, are there any algorithms for kyphoplasty?
The kyphoplasty algorithm has not been developed. We have talked about it. We're in the, we probably will be developing that in the next few months. Our group of spine specialists as a whole, as you've already seen by the algorithms I presented, have a very conservative approach to kyphoplasty and vertebroplasty, where we feel that this technique is certainly very valid, but it's a valid and fairly expensive pain technique. in that the real problem in a patient with a compression fracture is their underlying osteoporosis and their probable lack of conditioning. And so, and we recognize that the majority of compression fractures heal on their own and do not merit any sort of intervention. So typically, unless the pain were to be disabling and debilitating, we encourage a conservative approach, and only after that has obviously failed do we consider the interventions of kyphoplasty or vertebroplasty. And even then, we recognize, as I said earlier, that this is just an expensive pain procedure, and we encourage the patient going back to the primary care provider to develop some program as to managing their osteopenia or osteoporosis, and we certainly also involve them in an exercise program so that they can do conditioning appropriate exercises to help the underlying condition. I don't know if that answers.
Sorry. So what are your thoughts on using algorithms for osteoporosis screening?
I think that in any aspect of medical care, the effort of a community in developing algorithms would be worthwhile. The complexity starts increasing when you need to have the perspective of key specialists to develop that algorithm. When it comes to the osteoporosis algorithm, we have not developed it, and in great part because we feel that this needs to be predominantly managed by primary care. And if we were to go in that direction, what we would be bringing in would be endocrinologists along with primary care specialists and physical therapy specialists to try to see what would be a valid algorithm to put into play into our community. But we have not done that at this stage.
What percentage of patients are self-referred, and what is the process for these patients?
We have developed a strong partnership with our primary care physicians and have not embraced self-referral. At this stage, we think that this is working well in our community and have not opened the door for that type of referral to our facility. So we do not do self-referral. One thing that Jane, who's sitting here with me, wanted to present is that when we give our healthy back classes to the community at large, we do offer bone density screening. But when it comes to us having an algorithm for the condition as a whole, we have not, we do not have that worked out as of yet.
Okay, what metrics do you use for your outpatient spine center?
The main metrics we're using for the outpatient spine center is some of the metrics that measures the actual efficiency of our spine center to bring in referrals on a timely basis. We also measure ourselves as to how promptly the specialists review the cases. I might add that the value of the spine center triage program has been so substantial that to date we still have all the reviews being done gratis by our program, and we measure the rapidity or the promptness with which we review these cases. We also track the utilization of pain specialists, trying to put some common sense limit in some of the procedures that they do, and that's been part of our pain management algorithm. We track any and all testing that our partners do within the spine center, specifically the spine surgical specialist, so we can keep track of our own utilization and see if there's reasons to modify that. So we keep track of that. We also keep track of the lag times on patients being not only seen by the pain specialist, but also seen by the spine surgical specialist and also seen by the physical therapist. One of the things that we've been able to work out and really help in the solving of the fragmented spine care in our community is bringing in the physical therapist into our concept piece. And so the physical therapist, and I mean the independent physical therapists together, have developed algorithms to help guide the quality of therapist that manages our spine patients and the type of therapy that's provided to our spine patients. And we keep track of that. And of course, the outcomes that I showed you are outcomes we track on outpatient care as well. And by that, I'm talking about the NDI, Oswestry, and the other outcomes I showed you on that slide.
Okay, so piggybacking off of that question, this is a two-parter. How many pain management specialists do you have, and how many surgeons? Or asked a different way, how many non-op specialists do you need per surgeon to be able to offload the non-op patients from the surgeon's schedule?
I do not know that we've developed the ratio that is ideal. I think that right now we have 3 main pain specialists that we resort to with varied efficiencies, but they're the 3 main pain specialists. We have a group of physiatrists that are they number up to 5. The orthopedics are partners in our spine center as well, and yet in our community, the spine specialists, or the spine surgical specialists, are exclusively neurosurgeons. So the orthopedics are partners in that. Anything that involves an orthopedic entity, we refer to them. We, of course, involve when the problem by our review merits neurologists. And so those are I guess, outside of the physical therapist, the main non-surgical specialists. We have in our area 6 neurosurgeons doing spine surgery. I do not know, again, that I could answer what is the ideal ratio. Right now, we are able to manage adequately with the numbers that I've just described to you.
Okay, thank you. Another question that just came in, how many nurse navigators do you have, and are they located in the neurosurgery clinic practice? And piggybacking off of that, there was another question referring to a majority of patients not being involved in the spine center. So how does this whole process work?
I'm not sure that I understand the second part of the question, but let me start with the first. We have, in the actual spine center, we have the manager of the spine center, and she has working with her 3 nurse navigators, triage nurses. Okay, so we have in the spine center itself 3 main navigators. That includes the manager herself because she's so involved, and that helps manage the input to the Collada triage program. In the hospital, we use 1 hospital nurse navigator in addition to what I've described, and this is to help coordinate the policies and communicate with all the different aspects within the hospital that we need to involve as we have standardized our practices. The volumes that we are handling with the system I've just described to you is about, it's up to 300 a month. And we've been able to manage that reasonably well at this stage. I think that it would be, the way we're structured right now, prohibitive to consider self-referrals. But I have to also add to that that our results are very rewarding the way we're structured.
All right, switching over to outcomes. Is there a standard time interval? I've noticed your spine center doesn't collect post-op month 1 and 3.
We started collecting month 1 and 3, and add also 6 months, a year, and 2 years. Anybody who's doing outcome studies will find out that that task is dramatically demanding, and we also saw patients getting outcome fatigue. In addition to the fact that we were getting staff fatigue. And so while we started with 0, 1, and 3, and then 6 months a year, we really saw more valid information about what we were doing by getting, of course, before they had any intervention, 6 months, a year, and 2 years out. This, if the need arises, may change in the future, but at this stage, we're satisfied with that that sequence. The problem we continuously face in doing our outcome studies is just that, the patient outcome fatigue, and not having sufficient incentives to have them filling them out with a great regularity. We're starting to develop a phone aspect to the outcome tracking that I think is going to be letting us have better results, but that has been our experience.
What are your collection methods for functional outcomes?
For where we use the ones you're seeing there, we're using oswestry, which is self-reported, and the same thing with the NDI, and when it comes to pain scale as well. And the collection method is we send a questionnaire out, but we're, as I just alluded to, we're going ahead and also starting to do direct phone calls to try to get better results. We do have our spine surgical specialists, when it comes to surgical patients, sharing their evaluations, the direct physical evaluations with these patients, and at least the ones that they follow that far out, which is usually fusions, we have that information. But that's the only way we keep those outcomes. That's the only way we do those outcomes at this time.
All right. You mentioned Salem does community education regarding back issues. Who do you market this education to, and what type of information are you sharing with the community?
We basically market them at large. We certainly have, we share that information with the different clinics so they can refer their patients to it. But we put this in newspapers. We really have, and we announce them in radio presentations. And our goal is anyone interested in trying to understand more about their spine and spine care. And the focus is, without a doubt, talking about some of the services we provide in the case you need specialist care, but we emphasize the absolute importance of lifestyle choices when it comes to impacting their spine care, such as smoking cessation, weight loss, conditioning exercises, good body mechanics. And we do this in conjunction with our physical therapists that help give those classes in our public presentation.
What changes did you make in your OR protocol to eliminate post-surgical infections?
We adopted the nose-to-toes program to try to deal with infections in that fashion. We, of course, have this, what I think are fairly standard prep systems to have the patient already be conscious about taking care of themselves before they come into surgery. In our education classes, we emphasize different things that they should avoid as they get themselves ready for surgery. In the actual surgical area, we developed a certain precautions and routines when it comes to draping the patients and draping our C-arms, and also routines in how we prep ourselves, where if we did not do a double prep, we use double gloving as a system of managing that. More recently, we've adopted the idea of employing either dilute betadine, 50%, or vancomycin powder as we complete major spine instrumentation cases. And then post-operatively, I think our standardization routines have served us well, have served us well also. So I think that it is the whole focus that I think has led to our infection decrease. I think that by highlighting this as an issue, but involving all the partners that are involved with touching that patient when they come into the hospital, this has really, I think, helped our results. Now, we have, of course, adopted national standards that I'm sure have also helped with our infection reduction. By that, I mean using standards as far as IV lines and rapid attention to Foley removal and things of that nature. But I think that it's the composite of everything that I've told you that led to the improvements that we have achieved. And we really went about this aggressively because I think we were concerned about our statistics. And clearly concerned about our patients, since I think that there's nothing more decimating for the patient than the issues that arise after having an infected back surgery.
All right, this will be our last question for today. We'll still take them, and we'll send out a follow-up email with all of the answers to your questions. But Dr. Collada, do you see a need for nurse practitioners in the system to help offload referrals to the surgeons?
I think that is our goal in the future. I do think that would help handle volume. So I do see that as valuable. I think one of the key components is making sure that any nurse practitioner that we would bring into our program would spend time with our spine surgical specialist, would be well-versed in our philosophy, our algorithms, and essentially be what they do so well, which is become extenders of the practitioners they help out. But the answer is yes. We're not there yet, but it's a goal.
All right. Well, thank you, Dr. Collada, for your presentation, and thank you, everybody, for attending today. We will be sending a copy of the presentation as well as the recorded webinar out in a few weeks here. You'll be able to access the recorded webinar on our website at cordadahealth.com, And make sure to check out our events page to see a schedule of the upcoming conferences we'll be attending, as well as the future webinars we'll be co-hosting. Don't forget to also look at Dr. Collada's Cubanissimo Vineyards. Check out some wine there. I'm sure it's amazing. I plan on doing it myself. And I hope you guys all have a great day.
Thank you so much for having me.